السلام عليكم ورحمة الله وبركاته. مساء الخير على الجميع. دكتور عبير رشيدي, Program Director of Pediatric Residency Board in القصيم, and the course coordinator. Welcome in القصيم Pediatric Clinical Course. Today our workshop about data interpretation. As we know, it is the important station in Saudi Council clinical exam. We're presented by Dr. Mohammed Hussein, pediatric gastroenterologist and endoscopist. He's American and Canadian board certified in pediatric and gastroenterology. He joined us in MCH this year. Welcome, Dr. Mohammed Hussein.
الله يرضى عليك دكتورة. تسمعوني واضح؟
أيوة.
تمام. السلام عليكم ورحمة الله وبركاته. Next slide. So what we'd like to do today, okay, next. So I would like to have some sort of interactive session. If you guys have any question, please, I'm not sure if they can يرفعون ايديهم إذا عندهم أسئلة كذا. تمام. أنا برأيي إنه تسألون الأسئلة في وقتها، يعني ما تخلون الأسئلة الأخيرة، لأن عندي سلايدات طويلة وحاولنا نقسمها إلى two sessions today, inshallah, and tomorrow, and hopefully we can get things done today. So the first station, so you are, the following are results of cardiac cath in a 3 days old with congenital heart disease. Can anybody give it a shot and try to interpret what's going on with this child? Anyone? So I can help you a little bit. So look at the you see the PA, the pulmonary artery. You can see the saturation is 83, which is more than the or kind of almost better than the aorta. So you have the pulmonary artery 83, the aorta, which is the last one, is 82. Does that give you a hint? Anyone?
دكتور ممكن تختار ويفتح له المايك صلاح.
دكتور عبد الله. دكتور عبد الله تسمعني؟
صلاح تفتح الدكتور عبد الله؟ أيوة تمام.
أنا ولا عبد الله ثاني؟
اتفضل دكتور عبد الله.
ما أعرف صراحة.
ما تعرف. مشاري, you want to give it a try? You seem to be writing something. Mishari, quick, because otherwise we're going to be staying here forever. I'm happy to just give you the lecture, but I think it would be better to be interactive.
صلاح تفتح الدكتور مشاري؟
دكتور مشاري
سامعني يا دكتور؟
اتفضل.
I believe since the pulmonary artery is almost greater than the aortic, this gives me a hint that this might be a PPHN.
PPHN, okay. But you look at the pressure in the pulmonary artery is 24, but the aortic is 79. So the pressure is still in the aorta is more than the pulmonary artery. I think the drive home message in this slide, you look at the saturation in the right side. If the right side saturation is bigger than the left side saturation, so this is a transposition of a great artery. So this is a TGA with VSD because there is a bit of mixing as well, right?
Mm-hmm.
So diagnosis would be TGA. What would be the current treatment? The current treatment would be a switch operation with the switch operation with the VSD closure. So what is a TGA? TGA is the saturation in the aorta is usually lower than the pulmonary artery and is lower than in the other chamber of the heart. Usually management, this is a duct-dependent lesion. So you have to keep the duct open by giving a prostaglandin infusion if you got asked about management. You also say correct the metabolic acidosis, ventilation as required, give diuretics. If there is a heart failure, give inotropes if there is a blood pressure issues. And sometimes if the duct is too closed, you need to do arterial septotomy, which is could be done by experienced cardiologists, and sometimes it's a life-saving procedures. And eventually, the total correction can be performed at any time, preferably as early as possible by experienced surgeon, cardiothoracic surgeon. Next. Slide, Thani. So that's kind of the approach to your cyanotic heart disease. So if you have cyanosis and murmur, so your child is cyanotic? Yes. If you have a murmur, then think about tetralogy of Fallot. If your child is cyanosed and no murmur, think about a TGA. And you can follow the other algorithm, which is the acyanotic. That's for you to, not sure if they get the slide or no. يحصلون السلايدات ولا؟ تمام، ممكن نعطيهم السلايدات. تمام؟ So they can review it. Otherwise, we need to keep going. Okay. Next. The slide. Come on. So now I need a quick volunteer by the time I finish reading this question. 15-year-old girl is referred to you with menorrhagia and anemia. She suffered from frequent bruises during a basketball game. Her mother is concerned about her excessive loss of blood during her period, which is menstrual cycle. You've done the CBC, the hemoglobin is low, the MCV is okay, white blood cell is okay, the platelets are okay, the PT is normal, the PTT is prolonged. What's your most likely diagnosis? What other 4 investigations are indicated in this case? And what is the inheritance of these conditions? Go ahead. 2 participants raise your hand. افتح لهم اللي رفعوا ايديهم. افتح لهم. أصالة، تفضلي دكتورة أصالة.
أهلا دكتور.
So, what's your
طيب
likely
دكتور
diagnosis?
فون ويلبرن disease.
عاشت إيدك. What's your 4 investigation you need to do?
Initially, I think I should do mixing study to check if there is any factor deficiency.
Okay.
As well as
Go ahead.
ممكن نسوي المانوال platelet number والفون ويلبرند نفسه الأكتيفيتي يعني الأكتيفيتي for the فون ويلبرند.
Okay, so you want to do a von Willebrand factor antigen assay. You want to do the factor 8 assay. You want to do a platelets aggregation with the ristocin assay, and also do a family study, which is kind of plot the family tree if there's any bleeding disorders. What's the mode of inheritance of von Willebrand, Dr. Asala?
هو autosomal recessive بس type 1 و 3 هو الدومينant.
Excellent, excellent, perfect. So we can say autosomal recessive, dominant, depending on the type. Okay, excellent. So next. So anybody can give me a try for this EEG. This is a sleep EEG for a 9-year-old girl referred to the outpatient department with the history of generalized seizure and abnormal movement of the mouth during the seizure. So honestly, even if you don't know how to read EEG, there are a buzzword in the history can tell you the diagnosis. And the buzzword here is abnormal movement of the mouth during seizure. She had 3 attacks, all of them at night while sleeping. Okay. Dr. Asala, you seem to be on fire today. تفضلي.
So maybe this is absent seizure because there is automatism, the mouth during moving during seizure.
Yeah, but absence seizure does it happen during sleep?
صح no maybe
Right.
myoclonic seizure or Rolandic.
Excellent. This is a benign Rolandic epilepsy of childhood. What can you appreciate on the EEG? If you look at the EEG, you
في
can
temporal changes
exactly.
تكون.
There is a. I don't have the pointers to point, but if you look, if you focus on the central temporal, the central part, which is the C and the T, you see a lot of the spikes. So this is called, the other name for the Rolandic epilepsy is called central temporal spikes and waves, right? And that is a classical EEG for the Rolandic epilepsy, and usually happen during sleep. This is a most common form of epilepsy in childhood, usually found in about 15 to 20% of young patients with epilepsy. The onset usually around 3 to 13 years. About 40% of them, of a close relative, have been found to have history of febrile convulsion. So febrile convulsion history is very important, or they can have a family history of partial and generalized seizure as well, right? And the neuroimaging usually normal. So what further investigation needs to be done?
Maybe I should do electrolyte and glucose level.
So the right answer would be none. What is the
Okay.
treatment?
Treatment, nothing. Because
None.
maybe
Exactly. The treatment is none. Treatment is not required unless episode happened during the daytime. During daytime, meaning interfering with the daytime, especially the child going to school and interfering with the school, then you treat it. And if it's too frequent or there is a parental concern, that's the only three indication for treatment. If you want to choose a treatment, you usually start with the carbamazepine. If there is no response, you can do a clobazam or sodium valproic acid or lamotrigine. About 80% of the seizure respond to anticonvulsant. The prognosis is very excellent, and usually EEG normalize within a few years of the disappearance of the seizure. Next. Okay, so you have, this is a family tree of child diagnosed with Duchenne muscular dystrophy. What is the mode of inheritance? Dr. Mishari. Dr. Mishari?
Yes, doctor.
What's the mode of
X-linked
inheritance here? What's that?
X-linked recessive.
Can you explain to me the diagram? So what
Yes,
is the risk of being affected or carrier in this?
Yes,
Just explain the diagram and answer to me the second question.
Okay. So the
Explain
mother
to
is
your colleagues.
carrier. Then
Excellent.
the mother is affecting the boys. So the boy will be affected, and the girl will be carrier.
Right. So the male could be affected, and the male could be a carrier because the mom is carrier, right?
Yes.
So and usually the girls, it's excellent. So usually the daughters of the affected male will be all carrier of the X-linked gene and affected by an X-linked dominant. A woman who is a carrier will have 1 in 2 affected sons. A half of her daughters will be carrier if the disease is autosomal recessive, and half of the daughters will be affected if the disease is X-linked, depending. But it's usually the most common is X-linked inheritance. Next. So 14-year-old girl is admitted with the history of abdominal pain. There is a tenderness over the right upper quadrant. A splenectomy was performed at the age of 10 years. Her hemoglobin is okay, white blood cell okay, platelets okay. Blood film shows a spherocyte, anisocytosis, and Howell-Jolly body. What is the most likely cause of her abdominal pain? Now, here you need to know what's going on. What's the primary issue? Anyone? Well, nobody's raising hand. Asala, I mean, if she's raising her hand, she will take the fire. Okay, Dr. Asala.
أهلا دكتور. Maybe spherocytosis with gallstone.
Excellent. And what's the next single most useful investigation?
Osmotic fragility test for the spherocytosis.
Excellent. But in this context, what is the single most useful investigation? If you're thinking
abdominal ultrasound.
Excellent. So think in the context of abdominal pain and you think about gallstones. So the best answer would be abdominal ultrasound. If the question would be what is the next step, then you need to confirm the diagnosis, right? Okay, next. Okay, a 6-year-old boy, a 6-year-old infant to present with the water diarrhea and nappy rash, diaper rash, and which has been present for the last 2 weeks. The boy was born by normal vaginal delivery, weight is 3.2. The mom is concerned about failure to thrive. There are 3 uncles died early in childhood. Okay. Your platelets is okay. You can look at the hemoglobin is okay. The white blood cell is low. The neutrophil is low. The lymphocyte is low. Monocyte is low. The CD3, CD4, CD8 all low. And you've done phytohemagglutinin stimulation, which is some sort of a mitogen response, and it was no response. The rest of the immunoglobulins seems to be within normal. The calcium on the lower side, and the chest X-ray shows thymic tissue absent. What is the most likely diagnosis? Okay, Dr. Manal. Dr. Manal? I think you need to open the mic for her. Dr. Manal?
أيوة.
تفضلي.
This is primary immune deficiency versus secondary.
Okay, so it's a primary. If you want to give a syndrome, what syndrome?
Syndrome.
Thymic, absent thymus. Yes, I think you know that. Just say it.
Yeah.
It is. Somebody says Al-Anud, Ashat Idich, the George syndrome.
The George, yes. The George.
What's the mode of inheritance?
Autosomal dominant.
Excellent. What's your next step? Name one supportive diagnostic investigation. So somebody said fish. Dr. Asrar fish. Ashat Idich. Yeah. Tamam. Fish, which is a fluorescent in situ hybridization chromosomal anomalies, right? So the George syndrome, what is the George syndrome? It's a cell-mediated immune deficiency with low lymphocyte, right? You want to keep in mind if they ask you about hypocalcemia is usually due to hypoparathyroidism, which is another feature suggestive of the George, right? Clinical features, as we said, it's include hypoparathyroidism with the convulsion and tetany due to the hypocalcemia. Absence of thymus is usually associated with recurrent infection due to the impaired cell-mediated. Other feature is palatal abnormalities like cleft lip, cleft palate, feeding difficulty, conotruncal defects. That's the buzzword, conotruncal defect. Like what? Like tetralogy of Fallot, interrupted aortic arch, VSD, and vascular rings. Hearing loss and abnormal ear examination is important. They have genitourinary abnormalities like malformed kidneys, they have microcephaly, they have mental retardation, and they have psychiatric disorder like schizophrenia and bipolar disorder. And they have the T-cell immunity. And the management is usually, you support them with appropriate antibiotic treatment or whatever, and eventually the bone marrow transplant is the curative, okay? Next. So you have a boy, can draw a square and mimic a bridge with the cubes, okay? He can only say 20 single words and can name 3 colors. What is his age? And what further management should be required for his problem? Well, first you need to identify what's the problem for you to be able to say what is need to be done. Yeah.
السلام عليكم.
دكتور صالح.
حياك الله دكتور.
يا هلا.
Since he draws square, it's from 3 to 4 years, and but
4 years. 4 years.
But 20 single words, maybe he has a speech delay.
Excellent. عاشت. So what do you need to do? What is the
hearing assessment?
Yes, hearing assessment. And number 2?
Maybe total developmental assessment.
You need to have a speech and language therapy referral, right?
Yes. Yes.
That's very important. Okay. So you need to know your developmental milestone. You need to know there is a lot of things I cannot go. Okay, next. So you basically need to know your developmental milestone. Okay. Okay, so you have this EG of 4-year-old child presented with the DKA and was treated with IV insulin and normal saline. Blood taken 18 hours after treatment. Sodium is okay. pH is still slightly acidotic, well, normal. Potassium is low. ESR normal, chest X-ray normal, LFT is clotting normal. What is the abnormalities on the ECG? And what is the diagnosis? What do you see on the EEG?
Big T wave.
Where is it? Peak T wave. Where is the T wave? Okay, no. Can you show me the slide? No. افتح لي خلي أشوف. You said peak T wave. Are those T wave or QRS?
No, it's a QRS.
Exactly. You're looking. Don't be. Okay, so you thought. Okay, you said DKA. This is some sort of to do with the electrolyte. I'm gonna put peak T wave. This is a QRS. So what's the anomaly? Somebody said a U wave.
U wave.
Okay, what else? So you can appreciate ST segments depression. You can appreciate quickly if you do the segments, the QT interval prolonged, and you can see depressed T wave or slightly kind of flattened or U wave, the other name for it. What's the cause? I see somebody said, Dr. Mohammed Al-Amir. Okay, so this is a scenario. Somebody? Okay, somebody said hypokalemia. Okay, perfect. Next. So you need actually go back. ارجع للسلايد السابق. Okay, so you need to know that this is the manifestation of hypokalemia is the ST depression, prolonged QT, and depressed T wave or U wave. And the opposite, you need to know the hyperkalemia, which is peak T wave, prolonged PR interval, widened QRS interval, complex, and flattened or absent P wave. So you need to know this stuff, okay? You need to be able to calculate the QT interval and also calculate the corrected QT interval. That is very important, okay? Okay. There is manifestation, you need to be comfortable with the manifestation of hypercalcemia, like a QT interval shortening is very common, or the hypocalcemia or hypomagnesemia, which is prolonged, corrected QT interval and lengthening of the ST segment. And so these are the electrolyte manifestation. Hypernatremia and hyponatremia usually has no ECG manifestation. So get comfortable with the hypokalemia, hypo and hypercalcemia, hypo and hypermagnesemia ECG changes, okay? Next. Okay, 14-year-old girl known to have type 1 diabetes over the last 9 years. Has urine test showed albumin of 30. She is on a twice daily insulin, okay? Sodium is okay, hemoglobin A1C high, potassium okay, urea, creatinine okay, and LFT and clotting normal. What's the most likely diagnosis? Okay, دكتور محمد العامر.
دكتور
هلا حبيبي تفضل.
This is microalbuminuria.
Excellent. What is the next step?
Maybe we'll go for evaluate any damage to the kidney.
Can I hear you? What's that?
If there's any damage for the kidney itself.
Right. So I think the next, if they push you, what is the next step in diagnosis? The question would be, the answer would be renal biopsy. If they ask you what is the next step in management, I would say renal referral, like a renal nephrology consultation. You need to be aware of complication of type 1 diabetes. Usually we start screening for them, usually after 5 years from the time of diagnosis. It's different from type 2 diabetes. We usually start screening for them at the onset of the diagnosis. Yeah. So you need to be aware of the screening guidelines for visual impairments, renal failure, stroke, blindness, myocardial infarctions, and so on. Okay. Somebody said early morning sample. Yeah, sure. So I think the reason for that is you want to make sure if this is a orthostatic. Now, for the early morning sample, if you had a protein, not albumin, this is albuminuria, okay? So this is microalbuminuria, which is very common scenario with the diabetic nephropathy, type 1 diabetes or type 2 diabetes. So I think the next step would be renal biopsy and ask your nephrology colleague, okay? Next. Now you have 14-year-old, 18-month-old baby present with vomiting, failure to thrive, and excessive drinking. Okay, the urine, the pH seems to be on the acidic side. He has a lot of glucose, amino acid, and protein urea in the urine. Sodium seems to be okay. Bicarb acidotic. Okay. And potassium is low, phosphate is low, abdominal X-ray shows nephrocalcinosis. What is the likely diagnosis? Okay. Dr. صالح.
هلا دكتور.
تفضل
This
دكتور.
is renal tuberous acidosis.
So
Type
if
2.
you want to pick, if you want to, which one?
Type 2.
Type 2. What is type 2? Talk to me, distal or proximal?
It's proximal.
Why it's proximal?
Because there is a glucoseuria, amino aciduria.
Right. So when you have a proximal, you are dumping your glucose and amino acid and protein and phosphate and all the others in the urine, right?
Yes.
The proximal is the issue is with what? With not being able to reabsorb bicarb, correct?
Yes, but if there is a Fanconi syndrome, it will have all of these.
Right, right. So you will dump your bicarb. So you should have what? You should have, so that's Fanconi syndrome, right? You should have a alkaline urine, but this is a acidic urine. And also Fanconi, you don't see nephrocalcinosis. Nephrocalcinosis, usually you see it with the distal RTA. So what's going on? So this is a mixed picture of Fanconi. So I think the diagnosis will be Fanconi syndrome. The underlying issue is distal RTA, could be distal RTA, could be a primary hyperparathyroidism, could be medullary primary hypoaldo, or could be medullary sponge kidney. So this is the, when you have nephrocalcinosis, usually this is a distal RTA. But when you have a glucose-urea and amino acid proteinuria, this is Fanconi. So this is a challenging case of mixed both Fanconi and distal. So the primary diagnosis is Fanconi. The underlying issue is mixed distal and proximal, right? If you get asked why the distal usually have nephrocalcinosis, because in the distal RTA, the inability of the distal tubule to acidify the urine lead to persistently high urine pH, which is in this case, which that will promote calcium phosphate stone formation and deposition of calcium in the renal parenchyma. Okay?
Okay.
Next. So another EEG. Now, honestly, again, look at the stem. Even if you don't read EEG, sometimes there is buzzword. 4-year-old girl present with episode of daydreaming. Now, the challenge, if you don't give you any stem, they don't give you any history, they just say, read this EEG. That would be a challenge. Okay, Dr. Umar, you want to tell us why it's absence? Dr. Umar قال absence seizure.
Because I can see in the EEG there is 3 spikes.
There's what?
3 hertz. 3 hertz.
Excellent. So when you see those vertical lines, between 2 vertical lines is what? This is 1 second. And what do you see in each second? You see 3 spike and followed by a slow wave. Okay, so 3 spike and waves. So 3 hertz, spike and waves, right? 3.5. تقريبا 3.5 إذا تحسبهم. And it's diffused. It's all the brain. So diffuse, 3.5 spikes and waves. This is absence seizure. Okay. What would be your next step in treatment?
Ethosuximide.
Excellent. If you don't have ethosuximide in your pharmacy, what is your next step?
Maybe valboric acid, valborate.
Excellent. Excellent. Perfect. Next. Okay. So that's a bit of challenges. We need to spend some time in this. This is a 4-month-old baby present with the crying during feed. What's going on here? What is this anyway? Have you guys seen that before? That was on our Canadian exam for pediatric, not gastrology, for pediatric. Okay. So this is a pH study, Dr. Asmar Hijazi. You want to tell us more about it? You want to give Dr. Asmar? Asmar, Asmar Hijazi, yeah.
Yes, doctor, I did not see this study before, but I assume that it's pH study. I'm not sure the study exactly.
Right. So look at the, okay. Somebody said pH, well, okay. So when you look at the pH, so this is a 24-hour, so the diagnosis, before we jump into diagnosis, let's analyze the data. This is a 24-hour pH monitoring of 4-month-old baby having history of crying during feed. There's several, there's several points. You can see high numbers of reflux episode. The numbers of, if you appreciate the numbers, the second column, it says number of reflux is about 364 reflux episode, right? Mm-hmm. That's in total. That's a significant number. Both of them about upright, usually 190. If you look at the upright, it says 190. You see that number?
Yeah.
In the supine, you see 179, correct? What does that indicate? Indicate a frequent episode of gastroreflux. Now, also, you can appreciate the second point. You can say this is a prolonged reflux episode because there are 15 long reflux episodes lasting more than 5 minutes. Okay, so you can see the number of prolonged lasting more than 15 minutes was number 15, right? With the longest reflux lasting more than 15 minutes. You see that? The longest, more than 15 minutes. Okay, and most of these prolonged episodes happen in the, you can see, mostly 12 of them is in the supine position, correct? Right. Now, if you look at the other data, which is very important, the time of the pH less than, which is 1, 2, 3, 4, 5. I think the fourth arrow from the top, which is says time of the pH less than 4. The total time the pH remained below 4 is 238 minutes, with the fractionation time of the total 24 hours about 16% of the 24 hour. That is elevated. Usually the pH less than 4, the duration has to be less than 10%. But so the number here says the fractionated time says 16%, 16.5. So that's abnormal. He's spending a lot of time being less than 4. So interpretation, this is a significant gastroesophageal reflux. So this is definitely gastroesophageal reflux disease. So the next step would be you need to cover, basically the guideline says you start with the
and semi-upright position while feeding.
Right, excellent. So the new guidelines are from the NASPGHAN. It says if the mom is exclusively breastfed, you may try dairy-free trial for mom, dairy-free, cow's milk dairy-free, or sheep or goat, whatever. There's no difference between goat and sheep. They are all have the same casein, right? Give them a trial, dairy-free for mom for 2 weeks. If that helps, that's good. If it doesn't help, you may try anti-reflux formula, like a thickened formula for 2 weeks. If it doesn't help, you may try elemental formula, especially if there is suspicions of cow's milk or protein allergy. If it doesn't help, then go for the treatment, which is the PPI in this case. Okay, next. So get comfortable, don't get panicked. I think the next. Don't get panicked. So the next slide would be, this is audiogram of 3-year-old that sent to your clinic for a speech delay. What's going on and what's your next step in treatment? 2 participants raised their hand, okay? So let's see, we need a fresh blood. We need a new blood. Asala, we already know, no. We need Abdullah, no. Asma, no. Asala, okay. So that's just those 4 people, and the rest are what? Sleeping? Are you guys still sleeping? The rest? No? Okay, Muhammad Al-Am, okay. Asrar, no, Asrar, we have a new blood. Asrar. Dr. Asrar.
أهلا دكتور.
تفضلي دكتورة.
Yes, doctor. I see on the right, this is audiogram. I see the right side. There is the right side. There is a conductive hearing loss. Sorry, and in the left, there is as well. I think this is conductive as well.
Right, exactly. So that's both. So just to give you a bit of a background, the circle usually on the left side when I'm looking at the PowerPoint, the left side of my hand. The circles usually represent the hearing threshold for the right ear using air conduction, okay? So this is way below the 20th, so the normal is what? What is the normal? What's the normal? The normal range is 0 to 20 decibel, right?
Yeah.
If it's mild, usually between 20 and 40 decibel zone, And if it's moderate, between 40 to 60 decibels, severe loss is 60 to 80, and a profound loss is below the 80, more than 80 decibels, right? So this is lying between 20 and 50, right?
Yes.
So that's kind of mild crossing to the moderate conductive hearing loss, right?
Exactly.
Now, the axes usually represent the threshold for the left ear using air conductions. The triangle represents the hearing threshold of the left ear using the bone conductions, okay?
Mhm.
So you can see the bone conduction, which is the triangle, is within normal range. So that means it's a conductive issue. That means it's something in the middle ear, like a fusion or a glue ear, whatever it's called, right? If you have both the triangle coincide on the circle or coincide on the axis, then that would be sensory neuronal hearing loss, right? Next. Okay, so a child present with apneic spells during night. Can somebody give it a shot? What is this? What are you looking at, and what is this data? Anyone? Yeah, Dr. Muhammad. Okay, so this is a sleep study of a child presenting to you with the apneic spells at night. Dr. Muhammad.
I think this is overnight pulse oximetry.
Excellent. Okay, good.
Yeah,
So somebody said this is polysomnography. This is not polysomnography because there is a lot of data is not there. So this is as Dr. Muhammad said, this is overnight oximetry. Okay, go ahead. Can you interpret the data, Muhammad?
Actually, I'm not sure.
Okay, so so you need to be comfortable. Don't get panic again. Look at the data. Look at the data. So this child presenting to you. Can you open the? Close this one. So look at the data. So you're gonna say this is a sleep study evaluating a child presenting a apneic spell during night. The analysis suggests that the monitoring duration was about 4 hours and 1 minute because it started around 21 o'clock, which is what? Okay, and then ended up around 1:30 in the morning, which is around, I think it's, if you do the time, it's about 4 hours sleep study, right? And you can see the oxygen saturation, the lowest SpO2 recorded is about 55%. You can see that on the right side. It says here the low SpO2 is 55, right? That's a significantly low. The average SpO2 is 93, which is slightly below the normal range, which is more than 95. Now you can say there are 280 episodes of where the SpO2 was below the 85, right? It's tell you right there. It's SpO2 on the first top left box. It says SpO2 value below 85 was, even if you are not a respirologist, you just look at the numbers and you can say, well, that's too much. That's too much. Below 80% was 20 minutes and 48 seconds, which indicate a significant period of hypoxemia, right? And you can see that those dips, which is the bottom graph, dips in the SpO2 was associated with the increased heart rate, where the highest heart rate is the 214. So that is a classical scenario of what? Obstructive sleep apnea. Somebody said that. So this is the diagnosis would be OSA. Thanks, Dr. Asmar. So this is obstructive sleep apnea, whether it's a adenoid tonsil hypertrophy, whether it's a some sort of congenital upper airway, that is obstructive sleep apnea. So the next step would be, if this is proven to be a adenoid hypertrophy, the next step would be urgent adenotonsillectomy. Of course, you're going to do assessment by pulmonology colleague and ENT colleague as well, right? كيف نتحول next. Okay, anybody? So this is a recording of a ECG of a child who was resuscitated and transferred to the PICU. What's your diagnosis? What's your diagnosis? So good for you, Asala. This is VTAC. Okay, Asala, what do we need?
It's depend if the patient have pulse or not having pulse.
So I'll tell you, this child has a pulse, but he is kind of semi altered level of consciousness. What would he do?
So after stabilizing the patient, I will give amiodarone. Then I will give him a synchronized cardioversion.
Right. If he doesn't have a pulse, what would you do?
If didn't have pulse, so I will need to start CPR, as well as I will give shock defibrillation. Then I will give epinephrine.
Right. So if he has a pulse and altered level of consciousness, I would go for the cardioversion right away. I wouldn't waste my time, right? And they talk about sedating, giving some sedation for pain and whatnot. In real life, that doesn't work. Just go for the cardioversion. But what's the dose for cardioversion, Asala?
The cardioversion, I will start by 0.5 joule per kg.
Perfect. So the take-home message, children with the shock who have palpable pulse but condition is unstable should receive synchronized cardioversion, which is 0.5 joule per kilo, right? You can increase it to 1. Okay, you may try lidocaine, xylocaine, amiodarone, and whatever others, but I think you should go for the cardioversion. Don't waste your time. Next. Okay. Away from the complex stuff, just let's get some breather. Okay. 5-day-old present with vomiting lethargy and has not passed urine over the 18 hours. His mother is known to have diabetes since the age of 10 years. The baby has left renal mass. Sodium is okay, potassium okay, BU and creatinine. BU is okay, creatinine is quite high. Hemoglobin is okay, platelets low. LFT is clotting normal. Urine shows a lot of protein and RBC. What is the most likely diagnosis? If you get that, whoever gets that, you should get a pat to yourself on the shoulder and say, yes, I'm good. Neuroblastoma, nope. Asala. Not okay, somebody says, who said that? RVT. Can you open the Bashar? Open the Bashar. Tell us more about it. Okay.
Yes, doctor. I think it's renal vein thrombosis.
Okay, where is it? Which side?
In the left.
In the left side, right?
Yes.
Excellent. This is a left renal vein thrombosis. Can you tell your colleague why you concluded that?
Because there's a renal mass, which is the most common.
Excellent.
Renal vein thrombosis, and there's protein and RBC in the urine.
Good for you. Good for you. And there is a platelet low, which is kind of some sort of consumptive thrombocytopenia, but the clotting factors are normal, okay? So yes, somebody says hematuria, low platelets, triad, and a mass, which is, this is left renal thrombosis, okay? So why happen? Usually renal vein thrombosis is very common in the neonatal period, usually can complicate sepsis or dehydration, and it may be observed in the infant of diabetic mother and may be associated with the umbilical vein catheterization, or maybe as a result of from a condition that is hypercoagulable state, like, you know, clotting factor deficiency or SLE or thrombocytosis and whatnot. Renal failure thrombosis is rare in older kids, is usually common in little kids. Nephrotic syndrome can lead to it as well. And okay. Renal vein thrombosis in newborn generally characterized by sudden development of abdominal mass with the other triad we talked about. So flank mass with the proteinuria, blood cell, and hematuria, and thrombocytopenia, that is a give, okay? The next step in a investigation, you would do renal ultrasound or renal venography. Either one would be helpful. Okay, next. Now, 3-year-old present with the swelling of his face and abdomen. He is passing dark urine. What is the likely diagnosis here? Anyone? Okay, Dr. Asrar, talk to me.
Yes, doctor.
Talk to me. What is that? You said nephritic. You said nephritic syndrome with IC, not nephrotic. Nephritic. Can you explain to your colleague what you mean? You got it right, by the way. What do you mean by that?
Yeah, I think this is the category of nephritic. It is, there is many disease under nephritic, but this patient goes most likely with low C3 nephritic syndrome, as he's having dark urine, RBC in urine.
Excellent. And what's the list for your low C3 nephritic syndrome? What are those?
Yeah, most likely could be post-streptococcal glomerulonephritis.
Post-streptococcal, one of them, and also
myeloproliferative.
MPG and myeloproliferative. Next.
And could be SLE nephritis. Yeah.
Lupus nephritis, which is SLE. Next.
Shunt nephritis.
Shunt nephritis. Good job. Give yourself a pat on the shoulder. Good for you. Excellent. Next. So what would be the best site test can be done? No, go back. So the best site test you be done, you might say, I will do a blood pressure and I will do a daily weight. Okay, good for you. Al-Anud, blood pressure and daily weight. Okay, next. Okay, a 3-year-old present with vomiting and delirium, and she is confused. She just recovered from a chicken pox, right? Alkaline phosphatase is very high, ALT is slightly high, bilirubin, albumin, hemoglobin, glucose, amylase, glucose seems to be low. Amylase is high. Okay, good. Al-Anud, talk to me. You said Rye syndrome. Excellent, good for you. Why Rye syndrome? And what is it? Okay, you want to give Al-Anud access to talk? Al-Anud. Yeah, this one, Al-Anud Sami. Dr. Al-Anud, explain to your colleague what you mean by Rye syndrome and what would be the further 2 tests would you carry out?
There is delirium and so change in the sensorium. So due to encephalopathy with high liver function, high ammonia level.
Okay, so you would, if somebody asked you, would say, well, this is a sudden change in the level of consciousness after a some sort of viral infection, usually chicken pox, and there is a liver involvement, and there's a lot of ammonia, right? And so this is a Rye syndrome. What would be your next step? 2 tests. You would say, I would do clotting screen. I would do liver biopsy as well, okay? and you need to consult your gastroenterologist. So likely this kid will end up in a fulminant hepatic failure, and you probably will need an urgent referral to higher center. Okay. You need to stop the offending. Usually the typical scenario they present to you is a child having a viral illness and taking aspirin, and under the 12 years of age, that could lead to a sudden presenting of Reye's syndrome. The differential could be encephalitis, could be meningitis, could be diabetes, could be drug overdose poisoning, or even could be SIDS, sudden infant death syndrome, right? Sorry, abuse, meant to say. So that's kind of the differential diagnosis, okay? Next. Okay. 7-year-old girl present with the lethargy, loss of weight, and excessive drinking. Her weight is what, 22. Can somebody give me what's going on? Sodium is low, potassium slightly high, BU and creatinine okay-ish. Hemoglobin is, somebody said this is a DKA. Okay, Dr. Saleh. Okay, give Saleh. So, Dr. Saleh.
أهلا دكتور حياك الله.
Dr. Saleh, explain to your colleague why you think it's DKA. By the way, you're correct, but why you think it's a DKA?
Patient has lethargy, loss of weight, excessive drinking with bicarb 13 and positive ketones, positive glucose.
Excellent.
This is a DKA.
And what is your initial management?
First thing to do is to give bolus, normal saline, 10 ml per kg over 1 hour, then start insulin infusion and correct electrolytes.
Okay, so do you give insulin infusion or you give insulin subcutaneous?
No, infusion after the bolus.
Excellent. Okay. 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 So next, that's your initial management. So I think I was given this list. I think you guys have a station that comes, I believe, as similar to this. So they will ask you what's the interpretation. You already got the interpretation. The result we've given you. This is a. By the way, can you go back? ممكن ترجع? Can you calculate the anion gap here or no? Did I give you the information to calculate anion gap?
Okay. Sodium.
Yes, I've given you the information to calculate. I've given you the right?
Okay. 137.
Okay.
And chloride is 80. It's almost more than 20. It's high anion gap metabolic acidosis.
Right. So that's consistent with the DKA, right?
Yes.
Excellent. So you would say this is high anion gap, metabolic acidosis, you would get 5 marks, and you would say, how would you calculate the anion gap? You already did the calculation,
yes.
Right? And can you tell your colleague how to calculate it?
Yeah, you will just put the potassium and sodium minus the chloride and bicarb.
Excellent. And what's your differential diagnosis for the?
It's calculated in mud piles.
Like can you tell us what mud piles?
Yes, M for methanol,
right.
U for uremic acid, uremia,
right.
D for DKA, E
right.
for paracetamol, I for iron,
right.
and L for lactic acidosis,
right.
E for inborn error of metabolism,
or
and
maybe
salicylate poisoning.
Or ethanol, right? And salicylic acid.
Yes,
right.
aspirin.
Perfect. So there's a. And then they will ask you, what is this? If you were told that is this patient had history of polyuria, polydipsia, weight loss for the last month, what would be your diagnosis? Okay, DKA, you already got that. What's your management? You already got that. And can you give us the next slide? So that's from your exam. And when to stop infusion, when out of DKA, when to, what do you mean by out of DKA, when to start subcutaneous? Okay. So when to stop infusion, basically out of DKA when it's correcting, right? And to start when usually you're out of the acidosis, right?
Yes.
Endocrine, how to manage if hypoglycemia happen, what complicated. Okay, so that's beyond the, I'll leave that to you guys. Okay, perfect. Next. So it looks like, based on what was sent to me just prior to this presentation, looks like this this is a heavily like a tested station. So please, guys, focus on it. Okay. Perfect. Now you have 4-year-old present to you. Just came back from India. She has tachycardia, chest pain, and mild fever. And you look at her blood work. She has hyponatremia. She has a, what else? A little bit of acidosis. Bicarb is low. High white blood cells. CRP is quite high. And urine, a lot of sodium. And maybe a little bit of ketone. What is it? What is it? خلينا نختار ماكو أحد غيرهم بس دولة. اوكي دكتور محمد العامر رفع ايده. تمام تفضل دكتور محمد. دكتور محمد. دكتور محمد, what's going on? دكتور محمد. أصالة.
دكتورة, can be typhoid.
Okay, so I want you, don't give me the diagnosis. I want you to, I'm not asking about the primary pathology yet. I'm asking what's the interpretation of those biochemical findings? Why this child having low sodium, and why having low sodium in the blood and have high sodium in the urine, right? Okay, Abdullah, yeah, Abdullah said this is a syndrome of inappropriate ADS secretion. I agree with you, Dr. Abdullah. Give us more details. What does that mean? Secondary to chest infection, I agree with you. This is secondary to chest infection, right? So, but the underlying pathology, that could be a typhoid. I agree with you, especially with the coming back from India. So any chest infections, any intra-abdominal, any intracranial, that can lead to a SIDH. Also, certain drugs like NSAID, SSRI, cyclophosphamide, vincristine, and carbamazepine can lead to SIDH. Now, you need to keep in mind the main diagnosis of SIDH, you need to have hyponatremia, which we have that. You have serum osmolality less than 280. I'm not sure if we have that here. No, doesn't look like we have it. And you need to have a urine sodium more than 20. I think we have that here. Sodium more than, sodium was 40. And usually the urine osm is more than the serum osm, right? So you need to keep in mind that SIDH is a water issue. It's not a salt issue, right? It's a water excretion is impaired, but the salt handling by the kidney is normal, okay? So the hyponatremia is not a true hyponatremia. It's because of the water retention, right? Okay, next. The treatment is usually find the cause and treat it, and you do a fluid restrictions up to 1/3 of the daily maintenance. That's the initial way to go for management, okay? 2-month-old baby present with vomiting, failure to thrive, diarrhea, jaundice, and large liver and cataract. What is the most likely diagnosis? You have the sodium is okay, potassium, chloride, you have a, okay, Saleh.
I think the diagnosis is galactosemia.
Excellent. Why do you think it's galactosemia?
Because there is a reducing substance and high bilirubin, failure to thrive,
Right.
cataract.
Excellent, excellent. If I ask you, Saleh, since you are, you know the case, what would be the reducing substance? Is it a glucose-based or galactose-based reducing substance?
Wallahi, I am not sure.
Okay, so that would be a galactose based reducing substance. And what do you do the test to confirm the diagnosis?
Glucose 6-phosphate uridyl transferase
Okay,
deficiency.
so the RBC assay for GALD, which is galactose 1-phosphate uridyl transferase. Excellent, excellent. And what formula you put them on? Basically is a free from galactose and a free from lactose, because lactose is wet. Lactose is a glucose and galactose.
Okay.
Can they take soy? Yes, they can take soy. In fact, children with been fed soy and has galactosemia, they may present late, okay? So they only present when they are fed a milk, like breast milk, which has galactose, or fed cow's milk, which has lactose, because lactose has a glucose and galactose, okay? Excellent. Usually the reducing substance, if it tells you reducing substance is galactose, this is a galactosemia. If it's a glucose, usually that could be Fanconi or diabetes or renal glucoseuria, not important of metabolism. It's a different thing, okay? 6-year-old boy present with jaundice, lethargy, and not feeding well. The alkaline phosphatase is 1200. Albumin is 60, ALT 200. PTT is a prolonged, Billy is high, INR is slightly prolonged, ceruloplasmin is low, and urinary copper is quite high. What's your likely diagnosis? Dr. Saleh.
You, Dr. Most likely maybe it's Wilson.
Okay, explain to your colleague, what do you mean by Wilson? What is it?
Wilson disease, it's a genetic disease that causes a copper accumulation.
What is the mode of inheritance of Wilson?
Autosomal recessive.
Excellent. And it's characterized by what?
It's characterized mainly by behavioral changes with jaundice and lethargy.
Right. And due to what? What's the pathophysiology?
Pathophysiology, because I'm not sure صراحة, but it's copper accumulation.
Right. So it's a copper. So it's a copper deposition in the kidney, the liver, the brain, and other tissue, right? It's autosomal recessive and 13q, chromosome 13q. Usually, patient with Wilson present with the liver disease in the first decade of life. In neuropsychiatric, they talk about it usually in the 3rd decade of life. So as pediatrician, we don't see it, right? Adult will see it, right? And what would be other 2 tests to confirm the diagnosis?
I will do urinary copper 24 hours, as well as the serum copper.
You already have the urinary copper.
So I will do genetic study.
Before that, what would you do?
MRI liver.
Before that, what would you do? Just ask your ophthalmologist to look for Kasher-Fleischer-Ring. And somebody said liver biopsy. I agree with you, Dr. Abdullah. So the next step would be 2 tests to help and confirm diagnosis. Liver biopsy, we usually do the weight for the copper in the liver biopsy, which is, I think, forgot the numbers, has more than a certain cutoff, more than, I believe, 20 or something. And you do a slit lamp examination for the for the Kasher-Fleischer-Ring. What would be the 3-step in management?
So we should, after stabilize the patient, we should give him chelating agent like penicillamine and zinc.
Okay, so you do You do low copper diet and penicillamine and liver transplant. Tell them to stay from certain high copper diet, which is kind of the nuts, the peanuts, and there is a long list of diets, right? Excellent.
Yeah.
Next. And somebody's ADEC. Yes, of course. Eventually, they would need ADEC, right? The fat-soluble vitamins, right? And family counseling and tests for family. That could be included in the list of management as well. Okay. Now the next case is 5-year-old baby, baby boy present with history of nose bleeding and easy bruises. Okay. Bleeding time is 9. PTT is a prolonged. PT is a prolonged. Okay. Somebody says, okay, tell us, Dr. Najla. Dr. Najla, tell us. Dr. Najla, tell us, what do you think?
أهلا دكتور.
So
So this seems like a hemophilia case.
Okay.
B, type A. Hemophilia.
Okay, so it's factor what?
Factor 8.
Factor 8?
Yes.
But the factor 7 is
no,
not.
factor 7. Sorry, factor 7. Because it's liver.
So Abdullah says no. This is not hemophilia. What is it?
Come on.
So when you have hemophilia, you should have a what? The PTT or the PT is prolonged. But those are both of them prolonged. Yes, somebody, Asmar, Dr. Asmar. Dr. Asmar, that says factor 7 deficiency. I agree with you. This is factor 7 deficiency. An additional test you need to do, you need to test the common pathway, especially factor 9s and the you need to test the intrinsic pathway, which is the 8 and 9, 10, and 12 as well. So factor 7 deficiency is usually autosomal recessive. So you got to be careful. This is a trick question. This is factor 7 deficiency, right? And you need to know that's factor 7 is vitamin K dependent, usually presentation as GI bleed. Somebody says PTT. Right. So that's the question, is factor 7 deficiency, right? And that's not in isolation. We were saying this is the most likely diagnosis, but not the only diagnosis. There's other component because you have the prolonged PTT that suggests additional factor deficiency or combined bleeding disorder. That's why you need to look at the you look at the intrinsic pathway. But it's been said that factor 7 deficiency can give you the prolonged PT and PTT as well. I'm not sure if Dr. Abu Anza is with us, kind of speak up on that. He's the most expert. Okay. Next. You can see we're going really running. We have our speedo on running and we still have 31 slides. So that's going to be a long night. 8-month-old present with a seizure lethargy. What would be, looking at the sodium, potassium, what would be your diagnosis looking at this blood work? Anyone? You have high alkaline phosphatase, you have, okay, excellent, Dr. Sala. This is rickets. Can you tell us more? Why this rickets and what do you need to do next? And what's the treatment?
Because he's having high alkaline phosphatase, hypocalcemia with low 25 vitamin D.
Excellent, that's rickets, okay? And what would be your two further steps to help making the diagnosis? You already said vitamin D, and you already, I believe, said you would do an X-ray of the wrist and the elbow, right? And your treatment would be calcium supplement, vitamin D, and referral to dietitian, okay?
Yes, right.
Very simple. Next. So you have 13-year-old present with a vegetarian, has been vegetarian for the last 3 years, complain of lethargy, abdominal pain, and occasional excessive period. Her hemoglobin is low. Her MCV is quite high. White blood is okay, and her platelets also low. And there's a increased segmentation of neutrophil on blood film. What would be likely diagnosis? Okay. Dr. Asrar, tell us why you think this way. Dr. Asrar said this is, okay, speak up, Dr. Asrar.
Yes, doctor. This is vitamin B12 deficiency as the patient's vegetarian and the MCV is high. As well as
Excellent, good for you, good for you. Could it be folate deficiency as well?
Yeah, could be.
Okay, could be, excellent, could be, excellent. So that's called what? When you have the MCV is quite high, right? That is what?
Megaloblastic.
Megaloblastic,
and
macrocytic, right? Okay, excellent. Since you know that, what other what would be your what would you test?
May I will check the MMA, the methylmalonic acid, and the homocysteine.
You're overthinking it. You're overthinking it. So they are telling you vegetarian.
Yeah,
so
vitamin
I would
B12.
say exactly. Just go for folate level and a vitamin B12. Okay. Don't overthink things. When you're too smart, that's where you get in trouble. Right? Being too smart give you in trouble. Okay. Now this is megaloblastic macrocytic anemia. What if they ask you what are the causes of non-megaloblastic macrocytic anemia? You would say liver disease, severe hypothyroidism, and other blood disorder like aplastic anemia, red cell hypoplasia, myeloid leukemias, or drug-induced, like a drug that affects the DNA synthesis like azathioprine and imuran and others, right? So there are two types of macrocytic anemia, megaloblastic and non-megaloblastic. Megaloblastic being vitamin B12 and folate. The other is the one we just said, right? 5-year-old referred to you with a history of nocturnal enuresis that has been caused concern for the last 3 months. Recently has started to suffer from daytime enuresis and fecal soiling. So daytime enuresis and fecal soiling, that's not normal. On examination, he has decreased ankle jerk and reduction of sensitivity over the saddle area are noted. Spinal X-ray is normal. There's no birthmark on the back because there's no signs of spinal dystrophism. At which level is the lesion? List the 3 important causes. Name one single investigation of value in this case. Anyone? Nobody raised their hand. Okay, Abdullah, talk to me, Abdullah. Sir Abdullah, talk to me. It's right there. Sir Abdullah 18. Sir Abdullah, where's the lesion? So when you have saddle anesthesia, saddle area, and you have fecal soiling enuresis, that must be the S3, S1, S4, right? S1 to S4. List the 3 important causes that could be spinal space occupying lesion like neuroblastoma or sarcoma, or could be spinal dystrophism, or could be trauma. Name the single investigation of value that you need to have MRI of a spine with contrast, okay? Spinal MRI and nerve conduction study are the most reliable diagnostic tests, but also thorough neurological exam is important as well. Okay, next. Okay. You have 4-month-old present with the history of failure to thrive. Liver is 4 to 5 centimeter large and has cardiomegaly. Examination reveals gallbladder and engorged pedal veins. And investigation shows chest X-ray there's a lot of haziness and extending to both lower and upper lobes. White blood cells seem to be okay. Hemoglobin is quite low. Platelets okay. MCV is MCV is okay. Coombs negative. BU and creatinine seems to be okay. Bone marrow has reduced erythroblast. A normal blast means erythroblast. What is the diagnosis? Asala, HF. I don't know what's HF.
Maybe Dr. heart failure.
Excellent. So the diagnosis is heart failure. What is the most likely underlying cause?
Maybe due to malnutrition or anemia.
So, so you have Coombs test negative. You have hemoglobin is quite low. You have reduced erythroblast. Anything else? And you have a failing heart. That's what you have. So that is, I agree with you. This is some sort of anemia. Now the answer here, the one with from the board, it says diamond black fan anemia. I not necessarily agree because I don't have a lot of information to say this is diamond black fan anemia. I did not get this is absent radii or a triphalangeal thumb or absent thumb, or this is dysmorphic features, or or this is Caffi-Olay spot in case of Fanconi anemia. So I don't have anything. So we would leave it as a, somebody said the hint MCV. What do you mean by the hint MCV?
I mean, Doctor, diamond black fan sometimes have macrocytic anemia, and the MCV is almost high. It's not that big of a hint,
right.
but most likely.
Right. If we're assuming this is diamond black fan, then would be the mode of inheritance is what? Autosomal dominant, right? Okay, next. Nine-year-old boy referred to you with intermittent history of hematuria and a progressive hearing loss. His urine investigation reveals RBC, proteinuria, and creatine cholesterol. What's the most likely diagnosis? Okay, let's see. Saleh, Asmar, Abdullah. Let's give a chance to Asrar. Asrar, where are you, Asrar?
Yes, Doctor.
Yes.
Yeah, I think this is most likely Albert syndrome, as he's having.
Can you tell us what's Albert?
It is inherited disease. Most likely it is X-linked, but could be autosomal dominant or recessive. It affects the eyes, ears, and as well the kidney.
MashaAllah alayk, MashaAllah alayk. So you already answered the second question is X-linked dominant. What if this is a girl? What is the prognosis?
I don't know, but I think it's poor prognosis in boys.
Poor prognosis, I agree with you, poor prognosis in boys, and it's good prognosis in girls. Girls, they can have only hearing loss, sensory neural hearing loss. Kidneys function is preserved in girls, okay? Perfect. Next. 3-year-old boy presenting with a history of failure to thrive. There is no diarrhea or vomiting. His mother says he does get warm from time to time. She changes his nappy, which is diaper, up to 10 times per day. He wakes up crying in the middle of the night, asking for water. His sodium is quite high. His potassium is okay-ish. BU and creatinine is okay. Sodium phosphate, okay-ish. Albumin, okay-ish. Alkaline phosphatase, okay-ish. Serum osm is okay. Somebody says, okay, tell us, Dr. Asala. You said DI. You jumped and you said DI. Tell me.
Maybe it's going with the IS patient have polyuria.
Can you explain to your colleagues why DI and go through the result? Explain to them.
Okay, sure. Because DI usually going with hypernatremia as well as the urine osmolarity will be high. بس هنا normal, so not going with DI.
Do you know why it's normal?
I'm not sure.
Because he is waking up in the middle of the night asking for water. So when they are having access to water and hydrated, they don't need to drop. Serum osmolar will be maintained. Okay.
Okay.
Okay. So likely diagnosis, I agree with you. This is DI. What is other tests would you do?
So
Why this
initially,
child?
I will do water deprivation test to differentiate between DI and polysygenic polydipsia. Then after that, I will do the ACT stimulation test.
Okay. But why aren't you interested to know whether this is a central or nephrogenic?
Yeah.
Yes, somebody says a brain MRI. I agree with you. Whoever said that, Dr. Saleh, good for you. Brain MRI.
And the desmopressin response. So if the patient responds to desmopressin, this is central.
So I think if they asked you what additional tests would you do, I think it's fair to say brain CT or MRI. I would go for the MRI. And you will do a baseline hormonal assay like growth hormone, midnight and morning cortisol, and TSH and T4. Now, if they ask you what is the diagnostic test, or what will you do investigate further, then it will do the water deprivation test. Can you tell us more about water deprivation tests?
Yeah, so we'll do the patient will not drink water. Then after that, we will measure the urine osmolarity. If this is primary, this psychogenic, the urine osmolarity will improve. But if it's DI, it will not improve.
Okay, and DI if it's nephrogenic or the central?
Both.
Right, and then if you give desmopressin,
it will improve with the central, but the nephrogenic will not improve.
Good for you. Good for you. Excellent. Okay, a 10-year-old present with the UTI and abdominal pain. She is known to suffer from myopia. So she has myopia. She has been tested in the past and her blood has shown high level of methionine. Skin biopsy shows fibroblast culture showing cystathione beta synthetase deficiency. Sister died at 25 years of age with the clotting disorder. Protein is positive, slightly positive in urine dipstick and white blood cell leukocyte, and organism is negative. What is most likely diagnosis? Anyone? Okay, Saleh, tell us more.
Assalamu alaikum. Since the level of methionine high, cystathionine high, a deficiency, sorry.
Right.
And she has some sort of myopia and positive family history. This is most likely homocystinuria.
Right. And what other tests would you do to aid in the diagnosis? Very simple. You would do cyanide nitroprusside test. Cyanide nitroprusside test, which is a test usually looking for any sulfur-containing amino acid. In this case, is homocysteine. When you do the test, it will turn the urine test into a red-purple color, indicating there is a homocysteine. List the other features or signs of this underlying condition. You would say usually cardiovascular.
Tall stature, cardiovascular, and also myopia. Posterior subluxation of the lentis.
Excellent. Is it downward or upward?
Downward.
And what's upward?
Marfan.
Excellent. And do they have normal IQ or
no, decreased IQ.
Okay, so so the system are eye, CNS, and cardiovascular, right?
Yes.
Excellent. So that's kind of walking you through homocysteine and Marfan. You need to keep in your mind, I think here, what are they? I just want to show you something. I think you already said that. Oh, the heart is usually none in homocystinuria. It's the Marfan usually have the heart issues, aortic valve regurgitations, and the mitral valve prolapse. Okay. So I misspoke. So it's the eye and the CNS. Okay. 2-year-old baby preterm presented with the persistent bilious vomiting, 16-hour post-delivery. His birth weight is 2.4. His weight had fallen further down to 2 kilo. Investigation revealed this sodium is low. Okay. Dr. Sala, tell us.
Yes, doctor. So most likely the patient have hypokalemic, hyponatremic metabolic alkalosis. With this bilious vomiting, more going with biliary atresia as well, the age going with it.
Biliary atresia, you mean?
Yes.
Or pyloric stenosis, you mean?
Sorry, pyloric stenosis, but it's bile stain, so it's
So
biliary.
Exactly. So it's bilious.
So biliary atresia going more with the bilious vomiting.
But why this child having a low sodium and so there is a alkalosis. I agree with you. There is hypokalemic, hyponatremic, metabolic alkalosis.
Maybe
with,
the alkalosis, the vomiting.
Right. The urine sodium is okay, but the urine potassium is high. So what is that? So this is a simple pre-renal azotemia, right? Pre-renal azotemia secondary to the some sort of volvulus, some sort of intestinal obstruction, right?
Mm-hmm.
So you would say list the 3 abnormalities. We already talked about the sodium, the low sodium, low plasma, potassium, and high urine potassium, and high urine plasma urea ratio, right? Because you look at the urea, the BUN in the plasma is 26, and the urine is 280. That means the kidney is working well. That means this is a pre-renal azotemia, right? So that's a secondary to dehydration, so they can get you in all these kind of scenarios. So basically, this is a pre-renal azotemia due to some sort of dehydration, secondary to the bilious vomiting, secondary to God knows whether this is intestinal obstructions or malrotation, likely malrotation, especially with the bilious vomiting in this 2H preemie. Or God knows, could be neck, right? Okay, we talked about that. Okay. 22-month-old baby present with a history of progressive loss of vision. Her initially seen GP, 17 months of concern that was not able to follow object. Give me 1 second. His mother was reassured that time and was admitted further for investigation 3 weeks later. CT, okay, excellent. Talk to me, Asala. Asala said craniopharyngioma. Teach us. Tell us what's going on.
Most likely because there is classification in the suprasellar lesion. So this
Right.
usually going with the craniopharyngioma, as well the patient have loss of vision that affect bitemporal hemianopia.
Right. Okay. So what are the, so you already got the craniopharyngioma. The question is, I'm not asking you what's the second question is the diagnosis. The first question is what other clinical tests are indicated?
I need to do electrolyte to rule out DI, as well
Right.
as do other hormone like growth hormone, cortisol level to see, and most likely will be affected or will be low by
So the
hypertension.
question is, you got to be careful, Dr. Asala. The question is other clinical test. Clinical test. It's not investigation. It's a clinical test.
Maybe examine test urine dipstick. I will examine.
Urine dipstick is a lab test. It's not a clinical test. So somebody says visual. I agree with you. Visual field and acuity. That's Dr. Al-Anud. Shukran. And also I need to do a blood pressure and fundus examination. Okay. The second question is the craniopharyngioma. And the third question, then you can tell us about your case. Go ahead.
Yeah, so the investigation, as I said already, I will do the electrolyte mainly for the sodium. Maybe it will cause DI with this craniopharyngioma.
Excellent.
As well as I will do the other hormone, growth hormone, cortisol, because maybe it will cause panhypothyroidism.
Excellent. Okay, so list 3, usually you said urea, creatinine, glucose, osmolality of the urine and plasma, random plasma glucose, growth hormone, LHRH and TSH, and the last one is the brain MRI. Okay. Now, what's the management for craniopharyngioma?
Maybe most likely surgical treatment after stabilization.
Subtotal resection followed by radiotherapy is usually the approach for treatment. Excellent. Excellent. Okay. 6-year-old present with purpura. She has occipital lymph nodes and left cervical lymph. Examination of her limbs reveals absent right thumb. Absent right thumb. She suffers mild mental retardation. What's going on? Anyone? Any taker? Okay, Salah, talk to me. Dr. Salah, mashallah عليك.
أهلين دكتور حياك الله.
Mashallah عليك.
Since there is purpura with absent thumb, with the decreased mental intellectuality, this is most likely Fanconi anemia.
Excellent. Tell us what's Fanconi anemia.
It's a syndrome, skeletal with the bone marrow failure.
Right. So it's inherited as?
It's an autosomal recessive.
Could be some sort, sometimes X-linked. Okay. Excellent. They are at risk of what type of cancer?
Leukemia.
Leukemia. Honestly, all kind of cancer, and they're at risk of radiation, especially AML. I agree with you, Dr. Asra. AML, and they are at risk of avoid radiation. And what other physical findings would you look for?
You will look for cafe olate spots, absent thumb, short stature.
Excellent. 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 And what is the other investigation would you do?
Abdominal ultrasound.
Excellent. And
for Wilms tumor and bone marrow, if you are suspecting
right. And
leukemia.
I would do chromosomal analyses as well.
Yeah. Yes.
Somebody, Dr. Muhammad Al-Amir, said chromosomal breakage study. That's, I agree with you. Looking for the there are at least 13 gene mutation. So all of these are chromosomal breakage studies. They need to be done, and they're older patients. They have can develop other malignancy beside the AML, like GI, brain, neck, and anus malignancy. And you already said the short stature, the cafe olate spot, and the thumb anomalies presented usually only in 40%. Male can have some sort of hypogonadism, like issue with gonads. They can have microcephaly. They can have eye abnormalities. They can have structural renal defects and also developmental delay and abnormal hearing and abnormal ear shape as well. Okay, excellent. Can you guys hear me okay though? The sound is okay, right? No?
صوتك واضح دكتور.
Excellent. Now let's move on. 10-year-old boy present with history of generalized pain, high fever, and aches for the last 2 days. Both liver and spleens are palpable, 3 cm. Lives near lake and been swimming in the lake. And I'm telling you, this lake has some dirty dogs, just to make your life easy. Dogs, okay, dogs. He's from the Middle East, and the following results are obtained. What is going on? Okay, his hemoglobin seems to be okay. White blood cell, he had low white blood cell. He had sodium is low, potassium is low, BUN creatinine is okay. CSF high protein. Okay, what is the diagnosis? Anyone? Anyone? No. Okay. Ala, Dr. Ala, talk to me. Hydatid cyst, you said. Dr. Asmar, it's hard. Okay. So when you have generalized, okay, I'll take that. When you have generalized pain, high fever, okay, and you have liver and spleen enlarged, if I told you this child been around just sheep giving birth, then you would, or maybe drank some unpasteurized milk, or maybe travel somewhere to India or whatever, then you'll think about brucellosis and typhoid fever. If I told you this has been having a new pet and the pet is rabbit, then you think about tularemia. If I told you this has been playing with dogs and swimming with dogs and the dogs is pooing in the swimming pools, this is leptospirosis, okay? So leptospirosis is transmitted usually to human from infected animal urines, usually with a rat or rodents or dogs swimming in the pool. Or maybe even just the rats or the rodents roaming in the house and peeing on the food. So they can have the way to diagnose is you do a stool blood culture and urine culture is called Wales test serology, right? And you treat it the same way you treat brucella and so brucella, salmonella, tularemia, leptospirosis, rickettsia, all these things, rickettsial disease, rocky spotted mountain fevers, all these things that present the same. Okay. 2 days old infant has apneic attack and floppiness and needed ventilation for 17 days. Since then has been off ventilator and he has had hiccups. Hiccups. So the word hiccups makes you think about something, right? Don't read further. Usually hiccups can give you a hint of something. So you've done a plasma amino acid is normal apart from elevated glycerol, which is around 500. The plasma ammonia is okay. Lactate is okay. Electrolyte and urea okay. No ketonuria. CSF lactate is okay. CSF and the plasma ratio of glycerol is elevated. It's 0.3, right? So what is the likely diagnosis? Someone? Whoever gets that, that indicates you're a bookworm. Okay, Dr. Asrar, Al-Anud, you're on the right track. Talk to me.
Yes, doctor.
Asrar, Al-Anud, anyone? Okay, Dr. Asrar,
yeah.
Talk to me.
Yes, this patient, as he's having hiccup in neonatal period, it's most likely goes with hyperglycemia. Hyperglycemia.
Glycemia, not hyperglycemia, not a glucose, it's a glycine,
yeah,
right?
Yep.
Excellent. So is that ketotic or non-ketotic?
This is non-ketotic.
Right, because I just told you the ketone, there is no ketone in the urine. So this is non-ketotic hyperglycemia. Can you tell us more about it? What is that?
Unfortunately, I don't know much about it. Only that hiccup and brain. needed.
Okay. So the non-ketotic hyperglycemia is it's inborn error of metabolism caused by the deficiency in the glycine cleavage system. It's a very complex enzyme that breaks down the glycine in the body. And if you have this enzyme is missing, you have accumulation of the glycine in the blood. And more significantly in the brain. It's autosomal recessive. And the feature usually high level of glycine in the blood, high level of glycine in the CSF. And the CSF to plasma glycine ratio is usually elevated. And usually there is no ketone because the non-ketotic hyperglycemia does not involve any pathway that lead to significant ketone body accumulation. The way they present in neonatal period, they present with a severe hypotonia, lethargy, feeding difficulty, apnea, and hear me, intractable seizure. If you hear the other things beside hiccup, if you hear the word intractable seizure, seizure that is not responding to any seizure medication, think about non-ketotic hyperglycemia, NKH, non-ketotic hyperglycemia, okay? Usually when they grow up, they have developmental delay, they would have movement disorder, chorea, and that's when they get older, right? The treatment usually is unfortunately limited. You give them excellent, Dr. Manar, sodium benzoate. You give them NMDA receptor endogenous, which is the dextromethorphan, which is the cough syrup, the same to reduce the excitatory toxicity to the brain. And you do physical, occupational, and supportive, right? This is non-ketotic hyperglycemia. If they give you the same scenario, but there's ketone in the urine, then you will say this is ketotic hyperglycemia. And that is usually seen in the propionic acidemia, methylmalonic acidemia, and isovaleric acidemia, which is the organic acidemia, which is a different dog, okay? Perfect. That's basically what we talked about. We're breaking down that you're gonna have it for your record. Okay, what is this here? Anyone? Oh, I love that. Good job, Al-Anud. Asrar, talk to me. What is that? Okay, Hassan, Yaqub, molar tooth. Excellent. Talk to me. Hassan, we haven't heard from you. Talk to me, Hassan. Hassan Yaqub, yeah. Dr. Hassan. Dr. Hassan. Dr. Hassan, Mike, talk to me. You got it right. Talk to me. Okay, Dr. Al-Anud, Asrar, anyone?
Yes, doctor. This is a molar tooth sign. It goes with Joubert syndrome.
What is Joubert syndrome?
It's kind of neurological syndrome. They will present with hypotonia, developmental regression, I think.
Excellent. It's a genetic disorder, developmental delay, hypotonia, abnormal eye movement, distinctive breathing. It's called like the sigh breathing, right? And they have the molar tooth signs, right? And excellent. And okay, so that's Joubert syndrome. Next. And if I ask you, okay, we already talked about this molar sign. What is the diagnosis? Joubert syndrome. What is the molar sign? Why the molar sign happen? I think that's the overstretch. I think it's. I don't think they will ask you that. This is due to the signs due to the hypoplasia and aplasia in the cerebellar vermis, thickened and horizontally oriented superior cerebellar peduncle, and deepened interpendicular fossa. I wouldn't, don't worry about it. That's too much. That's kind of feels kind of neurologist board exam. How do you reach the final diagnosis? Of course, you're going to do the genetic workup. And what are the risks for GI? You need to think about GI. They are at risk of one thing, very major. It's esophageal varices. Whether it's a portal hypertension esophageal varices or normal portal circulation esophageal varices. Why? Because they are at risk of some sort of congenital anomaly between the spleen vein and the gastric vein and esophageal vein, some sort of congenital anomalies there, and they have varices there. We had a case, Draper syndrome presented with the esophageal varices, and one of our colleagues did the ligation, and you look at the portal circulation normal, liver ultrasound is normal, so we're looking further in to see if there is any underlying some sort of intra-abdominal venous anomaly. Okay. A 4-year-old boy present with a history of developmental delay, large forehead, prominent chin, and long ears. He also has macro-orchidism. What is the diagnosis? Okay, I agree with you, Sarah. This is a fragile X. And, okay, Dr. Mohammed Al-Amr. It's fragile X. Okay. Anyone?
هلين دكتور. This is a fragile X syndrome.
Excellent.
What's the mode of inheritance? It's X-linked recessive.
Excellent. What are the risk of?
Yes.
What is the main developmental issue?
It's there is intellectual disability.
Right. What if you want to choose one? Asala telling you ADHD. Would you agree with her?
Yes, they have ADHD, but the intellectual disability more.
What are the main? Okay, Manal, autism. I agree with Manal, autism. Okay, so they are mainly at risk of autism spectrum. Okay, but the others are correct as well. But if they ask a main developmental issue, then the answer would be autism. Okay, that's why you see fragile X differential diagnosis and a fragile X genetic testing is on every checklist of developmental delay, checklist of speech delay, checklist of autism. It's always there, okay? Newborn baby, newborn baby. Okay, Asala, can you read the question and tell us? I'm running out of steam.
Sure, Doctor. This is newborn baby, has dysmorphic features with microcephaly, micrognathia, and down slanting for palpebral fissure, as well as he having cat-like cry. So most likely this is cry du chat, defect in chromosome 5.
What is a cry du chat?
As I know that they have developmental delay, they have crying like a cat, and they having cardiac defect. That's what I know.
Excellent. You got all of them, okay? So they have a small head, low birth weight, poor muscle tone, microcephaly, characteristic cry, which is called cat cry syndrome. They have distinct features. They have, when they grow up early, older, they get language difficulty. Majority, they have a speech delay. There's a delayed walking because of the poor muscle tone, and later in life they will have scoliosis. Okay. Death unfortunately happen in early infancy or early childhood. Okay. And where is the defect?
In chromosome 5.
5 what?
It's deletion in chromosome 5, but I'm not sure. No.
5p deletion. P as in Peter. P as in Peter. Okay. 5p, okay?
Okay.
If you answer 5, you would get half mark. If you answer 5p, I would say 5. To get a full mark, you say 5p micro deletion, okay?
Okay, sure. Thank you, Victor.
Excellent. Okay, go ahead. Next, who's going to read that for me?
I can read.
Go ahead.
A term baby girl was born with lymphedema on the dorsum of the hands and feet. She has redundant skin on her back. This is most likely Turner syndrome.
I agree with you. Where's the defect?
It's trisomy, XO.
Okay. And if this girl happened to grow up, what is she's she risk at from the reproductive point of view?
She is infertile.
Infertile. Okay. Okay. Infertility. Excellent. 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 And can you tell me other cardiac features they could have?
Yes,
like, what are the cardiac features they have?
Yes, they will have the most likely they will have this is bicasp aortic valve.
Excellent. Somebody says coarctation. Somebody says coarctation, and you said, Dr. Abdullah in the note says coarctation, and you said bicuspid valve.
Yeah, this is
so
the most common. Bicasp aortic valve, then the coarctation.
Right. I agree with you, and I agree with Dr. Muhammad Al-Amir as well. It's bicuspid aortic valve is the most common, right?
Yes.
Okay. So they have coarctation of aorta. They have also bicuspid aortic valve, which is the most common. And they have high blood pressure, and they will have what kidney anomaly they have?
Horseshoe kidney, and they have normal IQ. They are intelligence.
Right. Okay. And what issue with the thyroid?
They will have hypothyroidism.
Right. And
the
what
risk of hypothyroidism, celiac disease also.
Excellent. Celiac and hypothyroid, and that's why they are a part of the list of the of kids. We screen them for celiac, even if they have no symptoms, right?
Yes.
Okay. And what is the gene defect on the X chromosome? There's gene defect. It's called
I don't know.
Shocks. Okay, it's XO. I agree with you, Al-Anud, but there's the gene defect on the X is so typically is 45XO, and the defect gene is the Shocks gene, SHOX, Shocks gene defect, okay? Which has a major role in the long bone growth. That's why they are short stature. They ask you whether they're short. Where's the defect? Is say because they have Shocks gene defect that is responsible for long bone growth. That's why they are short. And the same shock gene they have associated with the GI anomaly and Hirschsprung issue. That's why they are at risk of also GI anomaly. Okay. Next. A term baby was born with the ambiguous genitalia, no dysmorphic feature. A week later, present with lethargy and vomiting and is not well. And you treated for sepsis. Sodium is low, potassium is quite high. Urine is normal sodium. What is the likely diagnosis? Dr. Asrar, talk to me.
Yes, doctor. This patient most likely having congenital adrenal hyperplasia, as he had ambiguous genitalia as well as light imbalance in form of hyponatremia and hyperkalemia.
So if you told me in the exam this is congenital adrenal hyperplasia, I might give you half a mark.
Yeah.
What should you say?
21 hydroxylase deficiency, congenital adrenal hyperplasia.
I would say this is a salt-losing congenital adrenal hyperplasia, most common defect 21 hydroxylase deficiency, okay?
Yeah.
Should be very thorough and very, and usually the defect is the 6p21 hydrox on the 21, 6p21, okay? If I ask you and they ask you where is the defect, and I think we already answered the defect is 6p21, 6p21. If they ask you, give me the list of the blood and urine, sorry, if they ask you if this is a girl, sorry, if this is a boy, no, actually, I take it back. Who would be more at risk? The boy or the girl would be at risk of complication, and why?
I think boy, they will not having ambiguous genitalia initially. They will present later with
Right, so they get missed because they don't have a ambiguous genitalia. They will have dark scrotum and maybe big phallus, big penis. Okay. So the blood and urine tests in boys and girls usually will show a high level of urinary 17 keto steroid. They will have normal or low urinary. So what is the? I think there is no point of going through this. What would be the hormonal assay you would send for? Would be high.
17 hydroxyprogesterone in
Sorry,
this.
17. Okay, so the 17OH. Okay, perfect. I wouldn't go the rest because it's confusing, too much information. So 17OH is the okay. You need to know the CAH. There are the some of them they will have a no issue with the. They will actually have the opposite, especially the 11-hydroxy. They will have the opposite. They will have hypokalemia. Okay, and they will have high blood pressure. Okay, because the 11-hydroxylase pathway it's a very strong vasopressor. Okay. 18-year-old boy not walking yet. He's not able to bear the weight, and urologic exam is entirely normal. And you look at all the testing, sodium, potassium chloride, TSH is normal, except the CK is more than 2,000. What's the diagnosis and where is the defect? Anyone? That should be very straightforward, very simple. Okay. Who's speaking? I'm sorry. Dr. Muhammad? Dr. Manal, I haven't heard from you a long time. Dr. Manal, talk to me. You're on the right track, Dr. Manal. You're right. Talk to me.
Yes, Doctor.
Yeah, what is it?
Yes.
Explain to your colleague. Explain to your colleague why you think what you thought.
Unable to walk. This patient. First of all, he's a boy, and he's unable to walk and to weight bear his weight.
Mm-hmm.
So, and his neurological examination is normal. So he's going with muscle weak and dystrophy.
Right.
Most likely low Duchenne.
Duchenne. And where is
CK high?
The CK high. I agree with Asrar. Yeah. And where's the defect? Where's the defect? I agree, the dystrophin. Asala says dystrophin, but where's the defect? Where about? Which chromosome? It's XP21 in the dystrophin gene. Okay, I agree with you. Now, if somebody asks you, say, is it distal myopathy or a proximal myopathy? And what is the physical sign when they are sitting and they get up? How would they get up? And what is this sign called? Excellent.
Grower sign. Grower sign.
Okay, it's a proximal, and is it a grower or Gower sign?
Gower sign.
Gower is not a grower. Gower, you got to be careful, because if you told me grower, I will give you 0.
Yes.
So it's a Gower sign. Okay, so we say they get up on their feet, on their knees. They gradually, like an old man, old women, getting up. they يستندون على رجليهم يلا يقومون يعني because of the proximal myopathy. صحيح؟ تمام. Who's going to read that? Anyone? Asrar?
Yes, doctor. This is a 13-year-old girl present with tiredness, lethargy, and inability to move her legs. She has been well over the last few weeks, but since the beginning of the week, she has felt weak. She has never been abroad and apart from mild cold 4 weeks ago. She is healthy young girl. Lower limb reflexes are absent. Workup show normal CBC with differential CRP albumin, immunoglobulin. Cerebrospinal fluid showed normal cell count and elevated protein, 55, which consider elevated. Diagnosis most likely.
So what's going on?
Yeah, she's having GPS.
So what is GPS?
Guillain-Barré syndrome.
عاشت إيدك. صحيح. So that's Guillain-Barré. Guillain-Barré. The way we say it, some people say Guillain-Barré, but the way you pronounce it is Guillain-Barré syndrome. Guillain-Barré syndrome. Okay.
Okay.
So Guillain-Barré syndrome. What is the next step in workup?
Nerve conduction study and brain MRI.
Excellent. So nerve conduction studies. Okay. And what would be your next step in treatment?
IVIG.
IVIG. For how long? What's the dose?
I guess the dose is 1 gram per kg over 12 hours.
Once a day for 2 days. Okay. What is Guillain-Barré?
It is demyelination disease.
Okay, so it's acquired demyelination disease of the peripheral, characterized clinically by rapid progressive paralysis, areflexia, variable sensory disturbance. They could have some sort of disturbance. Now, can you explain to me what is this sign called when you have normal cell in the CSF and high protein? What is this called?
Yeah, cytoalbuminic dissociation.
Excellent. Mohammed Al-Amir as well said that. Albumin. So cytoalbuminic dissociation, meaning normal cell, yet I have high protein. So that's a classical CSF finding for Guillain-Barré syndrome. Okay. And it's usually comes after some sort of respiratory illness and that. Okay. And if they ask you what they are at risk of from the respiratory point of view,
they may have respiratory failures.
Right. So yeah, so you gotta watch them like a hawk and let the PICU team aware that they might decompensate, especially if they are showing signs of respiratory distress. So you need to move them and CPAP them or even sometimes ventilate them, right? Okay. Excellent. So do we continue or what? نستمر ولا نستمر شباب وشابات ولا شنو؟
Yes, doctor.
عندنا 153 سلايد، هسه وصلنا قريب فد ال 54 سلايد. 70 60 اوكي بلش نوصل لل 60 فد 6 سلايدات ونشوف على بكره ان شاء الله نكمل يعني.
تمام يا دكتور، ممكن نكمل على بكرة إذا الشباب حابين
دكتورة
نكمل
عبير
بكرة. أهلا.
احنا عندنا 153 سلايد، يا دوب خلصنا 54 سلايد.
تمام، ممكن نكمل ربع ساعة وبعدها إذا حابين نصير بكرة نكمل إن شاء الله بإذن الله.
تمام. So 5 days old baby present, okay, we'll do. 5 days old baby present with excessive crying, feeding less, and jaundice. His first child, he is the first child to a first cousin couple. So there's a consanguinity. There are no other concerns. Normal, CBC albumin, CRP, ALT, AST, AST negative, blood cultures, urine negative, DCT negative. Billy what is your diagnosis? So when you have normal albumin, normal liver enzymes, and DCT is normal, this is likely, and this is only 5 days, excessive crying, feeding less, and jaundice. That's probably physiologic jaundice. Now, I would go with the physiologic jaundice. This is, and the next step would you need to have fractionated bili and total and direct, and the next step in treatment, this is phototherapy. So don't get bogged down and worried about it, okay? So you have 6-year-old boy present with a temperature of 38. Over the last 5 weeks, every 3 days, his temperature has gone up to 39, settle after 4 days, and then so it's a kind of every 3 days goes up and then goes down. He's been coming from Kenya, and temperature developed after the 3rd day of his arrival. No one else in the family is similar problem. Blood cultures after 48 hours, no growth. Blood film on the 3 occasion shows no parasite. There's no malaria. TB skin test more than 15 millimeter. Chest X-ray reported to be as normal. LP shows high protein cell is mostly lymphocytic, and a gram stain, no gram. The rest of the white blood cell, hemoglobin and whatnot, CRP is quite high. So that's the question is, what's your diagnosis? So that's TB meningitis, right? What would be the next step in management? You would say PCR for CSF for Mycobacterium tuberculosis. The treatment would be oral rifampin, INH, pyrazinamide, and ethambutol for 12 months. Just for the sake of the time, I'm just going to run it through these stuff. 2-month-old present with the cough and not feeding well. She was full term, no previous problem. She requires 2 liters of oxygen per the nasal cannula. Episode of coughing lasting for 2 to 3 minutes, and she get apnea with those coughing episodes. So that's likely, especially when you get, where is it? Do we have the lymphocyte? Usually, I will tell you there is lymphocyte. Okay, so pertussis, I agree with you, Asala. What is the next step in workup?
We'll take PCR nasopharyngeal.
Yes, so nasopharyngeal swab. And what's your treatment?
We will start macrolide azithromycin.
Right. So you would macrolide for 5 days. It depends on what type of macrolides you're going to use, erythromycin and whatnot. You're going to be mindful for 2 months of age. When you put them on macrolide, you better be mindful of pyloric stenosis, okay? Risk of pyloric stenosis. 9-month-old present with the history of lethargy, not feeding very well, losing weight. She was born term and has been no concerns about her the last 8 months. Hemoglobin is 10, white blood cell is elevated, neutrophil is okay, elevated, sorry. CRP is high, ALT total bili is okay, alkaline phosphatase is okay, albumin is okay, and blood culture shows no growth, and MSU positive. Okay, so that's a UTI, okay? And also CSF, okay. So that's basically looks like a traumatic CSF because no white blood cell, no organism, blood culture is okay. So that's traumatic CSF. I would not buy this is sepsis. So that's a urine UTI. What is the next step in management? So you would need to do a renal ultrasound, next step in management, and treatment would be IV 3rd generation, I would start with, until we get the sensitivities back. So that would what would you say? 18 months old present with a history of lethargy, losing weight, and distended abdomen. There is a mass on the right side of the abdomen, okay, which is the examiner can go up and it crosses the midline. Okay, so the word crosses the midline. So if it doesn't cross the midline, it means something. Excellent. I agree with you, Asra. Neuroblastoma, Najla, neuroblastoma, all of you. Okay, excellent. So CRP, abdominal ultrasound. So this is right abdominal mass with the calcification, no kidney tissue. Okay, so that's a neuroblastoma. Next step in diagnosis, you would say bone marrow aspiration, and what is you would do urine catecholamines, and imaging you would do abdominal MRI or CT. Okay, excellent. And eventually going to do PET scan to see the staging, because usually they end up, by the time you diagnose them, they are already metastasized. They are very aggressive. And if they ask you, they're giving you this scenario and they ask you, okay, you know it's a neuroblastoma, but they ask you, list the eye signs, manifestation of neuroblastoma. What would you say? Raccoon, excellent. Horners, excellent. What else? Dancing eye. What is this, Muhammad Al-Amir? What's dancing eyes called? Opsoclonus. Excellent. Opsoclonus, dancing eyes, raccoon eye. Okay. And last one. Proptosis. Okay. Oh, no. Actually, proptosis is mostly on the retinoblastoma, not the. Okay. I take this back. 14-year-old boy present with a petechial rash, bruising very easily, and tiredness. You look at his spleen is the large, and liver is in the normal, and you look at his CBC seems to be okay. Platelets is very low. CRP is okay. The rest of the workup seems to be okay. What is the diagnosis? Somebody? Did I see that? Somebody said something? Okay, Muhammad Al-Amir. Sir Muhammad. Who? Asala? Asala, ITP, I agree with you. What else?
So mainly with isolated thrombocytopenia.
Right. If you have a petechial rash and very easily bruised, and this is a platelets, only platelets are normal. The rest of the workup is normal, and you have a large spleen. This is going with the ITP. If this is ITP, what would be the next step?
Usually with supportive management, we will give IV.
No. Sorry. The next step in workup.
In workup, if this patient the age is not typical, maybe we will do bone marrow sometimes.
Right. So what would you say? The next step in workup, I would say I would do nothing. I would just go ahead. If this is classically ITP, I would go with the treatment of IVIG. Now, there is a new classification. If you Google ITP, Canadian CPS, Canadian Pediatric Society ITP guideline, the new guideline is they classify them into minor, moderate, severe. Minor, if you have only bruises, in this case, petechial rash and easy bruising and tiredness. Even the platelets at 20, you can do conservative management. You just say, make sure there's a reliable parents, they live close to the hospital. So we don't treat numbers, we treat severity. So petechial rash, easy bruising, and the bruising is only limited in certain area, then I would do nothing, right? What? Mute? Okay, perfect. And then I would do nothing. If it's more pronounced, like, there is generalized petechiae and there's some joint, maybe a bit of epistaxis, kind of moderate, then I would do with they said they sit on the fence whether treat, not treat. If it's severe, usually like joint involvement and internal bleeding, GI bleeding, epistaxis, hematolosis and whatnot, then we'll go with the IVIG expedited. And always when you consider a steroid, you have to have some sort of bone marrow workup. 11-year-old present with the history of failure to thrive, and she is pale with no organomegaly, no lymphadenopathy. Her parents are from Pakistan and has been living in the UK for the last 15 years. Okay, so what is that? The hemoglobin is quite low, white blood cell is okay, neutrophil is okay, platelets okay, MCV is low, CRP is okay, total bili okay, alkaline phosphatase slightly high, and alkaline ALT is okay, albumin is slightly low, within normal. BO and creatinine, sodium is okay, potassium and corrected, and magnesium okay. So what's going on with this child? Okay. Who's had iron deficiency anemia? Can you speak up? You're right, iron deficiency anemia. Muhammad Al-Amir, can you speak up?
Yes, doctor.
Okay.
Okay, so
Why do you think it's iron deficiency anemia?
see the age itself, 11 months. A big factor in this age group. Patients present with failure to survive and failed. Systemic examination is unremarkable throughout infection. And in CBC, we have low hemoglobin, low MCV, with normal electrolytes. So it could be nutritional iron deficiency.
Right, I agree with you. So that's a nutritional. The next level in workup, you would do ferritin and level, and that's about it. And treatment iron supplement. Now it says here hemoglobin electrophoresis. I disagree with that because in Pakistan they are at risk of thalassemia. It's called Punjab thalassemia. So I disagree with that. Treat them. If they don't respond, then think about thalassemia later. So treat them first. Okay. Next. Done. خلاص. وقف. ها؟ 60 خلاص. نوقف شباب.
أوكي دكتور، نوقف إلى هنا وبكرة إن شاء الله بإذن الله نكمل.
تمام.
يعطيك العافية دكتور، شكرا جزيلا لك، تعبناك
لا.
معنا اليوم.
شكرا.